in pregnancy. So topics, we'll talk about Braxton Hicks, and these are a little bit of order. Topics: abortions, supine hypertension, preeclampsia, eclampsia, gestational diabetes, neuromuscular disorders briefly, placenta previa, rupture of placenta, preterm labor, and cardiac arrest in pregnancy. So Braxton's, see here, sometimes referred to as false labor, can happen as early as 13 weeks, and there's intermittent uterine contractions with Braxton's, and that theoretically enhances placental blood flow. They tend to be painless, irregular contractions, and don't cause any cervical changes, so no dilation. And obviously this is not an assessment that we would do in the pre-hospital setting anyway. Some of the characteristics of Braxton's include that they tend to be irregular. They decrease with walking, whereas true labor increases with walking. They may ease with change of position. There's no increase in frequency or intensity. Discomfort's located in the abdomen only, where it may be in the back with labor. And so true labor includes contractions that tend to be regular. Walking increases the intensity, not affected by change in position. Frequency and intensity increase, and discomfort oftentimes starts in the back and then spreads to the abdomen and possibly the upper thighs. What's going on here? Okay, so important piece, whether mom's involved in a small MVC or just at home and having Braxton Hicks, it may be difficult to distinguish between true and false labor in the field, and ruling out true labor in the field may put mom at risk of an unaided premature birth. And so my personal approach to cover my own ass is if they call 911, you're going to the hospital. End of story. I'm not going to make any the distinction between Braxton's and true labor at 19 weeks or 20 weeks or 16 weeks or what have you. So in terms of care in transport, really, sorry, we got a little bit of a delay going on here. Hang on here. Let's see. Okay, I think, yeah, my question was I was going to get you guys to tell me what care was in transport, but monitor, transport, comfort, that's it. I don't know that even left lateral recumbent is necessary in Braxton Hicks, but we're talking early gestation, and vena cava hypotension is probably not an issue, but if you wanted to do left lateral, then sure. Usually we see that more in third trimester. I got to be careful because I want to say semester, so I've been teaching too long. So, right. So for third trimester, left lateral recumbent would be appropriate, and just the usual ECG stuff, SpO2, O2, IV. Again, if there's actual potential need for IV fluids and medication, perhaps. Otherwise, I don't think anyone would criticize you for not starting an IV, and you're not likely to criticize for starting one if you do. Fluid resuscitation generally not needed. And ectopic pregnancies, I've had a few of these calls. Occurs as a result of a flaw in the reproductive physiology that allows a fertilized egg to implant outside the uterus, and so might implant in the fallopian tubes, the cervix, the ovaries, the corneal region of the uterus, the abdominal cavity, although I've never heard or seen of it happening in the abdominal cavity, and obviously ends in death of the fetus, but become a life-threatening condition for mom because of the risk of bleeding. The last ectopic pregnancy I had, she was a classic presentation. She knew she was pregnant. She didn't know if she was ectopic. She was lying on the floor right in the hallway of her house, and she was in exquisite pain, lower abdomen pain. She was about 6 or 7 weeks gestation, I think, and so we zipped her off to the hospital. She was hypotensive tachycardic, and she went in the OR. Apparently needed about 4 units of blood for resuscitation. It's the leading cause of pregnancy-related death during the first trimester, so this is something we wouldn't waste any time on in the field. And these are just some examples of where an ectopic pregnancy may implant. So the etiology, the cause can be anything that hampers the migration of the embryo to the uterine cavity, and that can be things like pelvic inflammatory disease, previous ectopic pregnancies, tubal surgery, or conception after tubal ligation, use of fertility drugs or assisted reproduction. Older patients and smoking would be another risk factor as well. But a lot of patients just don't have any particular identifiable risk. But anyone of childbearing years who has abdominal pain, NYD, is considered ectopic pregnancy until proven otherwise. But as a general rule with abdo pain, if it's sudden, if it's severe, and if it's constant, if it meets those 3 criteria, it's a surgical candidate until proven otherwise. So sudden, severe, constant. That should apply to men, women, any age. But if they're women of childbearing years, they're ectopic pregnancy until proven otherwise. Even if they're adamant there's no possible way they can be pregnant. Now, I'm not going to argue, but we're going to treat it the same. So the classic triad of ectopic pregnancy is pain, absence of menstrual period, and vaginal bleeding. But about 50% of patients present atypically, so it doesn't help matters a whole lot. And they may have some other symptoms common in early pregnancy, such as nausea, sense of breast fullness, fatigue, lower abdo pain, heavy cramping, shoulder pain, so dyspanuria as well. And in terms of management, you want to assume, as I mentioned, that anyone with childbearing years with pain, abdo pain, is ectopic proven otherwise. SpO2, O2, ECG, definitely an IV access. The left lateral recumbent I don't think is really important at all at that stage, but if you feel inclined to do so. And fluid resuscitation on a PRN basis and transport the patient ASAP. So abortion's therapeutic or elective. There are about 20 to 30 million illegal abortions performed annually, and fortunately we don't have this problem so much in Canada. It's a rare occurrence here by comparison to developing countries especially. And so abortions performed in the first 2 weeks are considered menstrual extractions, and prior to 9 weeks are performed surgically or medically, and 9 to 14 weeks are performed with dilatation and suction curettage procedure. So after 14 weeks, surgical abortion is performed by dilatation evacuation procedure. I'm not sure how many people have abortions after 14 weeks. That would be, I can't imagine what it would be like to go through that. So some post-abortion complications, and just curious, how many of you have had calls for post-abortion complications? I've had 3 or 4 with retention of products of conception.
I've only had 1, and I was a student.
And was she bleeding?
Yeah, I picked her up just off the side of the highway, just came back from the clinic, and yeah, there was like mild active bleeding.
I had one who was actually a friend of mine who worked at the airport, and I didn't even know she had had an abortion, and she was bleeding profusely. So that was a really uncomfortable call because I knew her quite well, and we transported to the hospital, and she ended up getting about 6 or 8 units of packed red blood cells in the process of resuscitation. So that was bathroom floor, almost the entire bathroom floor was covered in blood, and she was pale, pale, pale as a ghost, and her lips were as white as lips can possibly be. So post-abortion complications of the triad is a pain, bleeding, and low-grade fever. Those are the most common, and usually caused by retained products of conception. And hemorrhage can be excessive, leading to shock. Coagulopathies are not uncommon, so they have an inappropriate activation of the clotting cascade, and they undergo consumptive coagulopathy, and that can create some longer-term complications in hospital. Pain is typically increased lower midline abdo pain, and there may be uterine perforation, bowel injury, abdominal pain, fever, blood in the stool, nausea, vomiting. Bladder injury may present with suprapubic pain and hematuria. So we need to ask about bowel movements and micturition and any blood, anything unusual about bowel and bladder function. Septic abortions present with fever, chills, abdo pain, vaginal bleeding, and then failed abortion. Another example. In terms of management, I think I was going to get you guys to jot this down, but basically we treat for shock, right? So SpO2, probably O2 to compensate for the decreased oxygen carrying capacity, ECG, left lateral recumbent, IV access. Again, left lateral recumbent probably of little benefit, but you want to do, go ahead and do it. Treat for septic shock if we're dealing with septic shock, and that would be with fluid resuscitation, maybe patching for inotropes, depending if it's actually septic shock and not hypovolemic shock. Hypovolemic shock we don't treat with dopamine, we treat strictly with fluid resuscitation. And so preeclampsia is hypertension in pregnancy, essentially, and it's the most common hypertensive disorder, also referred to as toxemia of pregnancy. So terms used sometimes include the patient's toxemic or the patient's preeclamptic. The etiology is really not known, but one of the hypotheses is that placental dysfunction can initiate vasospasm, ischemia, and thrombosis, and eventually damage organs. Occurs after about 20 weeks gestation. Oops, what happened there? Unless the patient has a history of pre-existing hypertension, chronic hypertension, and it's one of the most common causes of perinatal morbidity and mortality. So mild preeclampsia would be an increase in systolic of about 30 millimeters of mercury, an increase in diastolic of about 15. So 140/90 is sort of the general guideline for hypertension in general, and this is a good guideline to use. If they're above 140/90, then any mild peripheral edema, headaches, proteinuria, if the patient's had protein measured in urine and can tell you, that would be an important question to ask. Let's see. Okay, so severe preeclampsia would be systolic greater than 160, diastolic greater than 110. And that can result in end organ damage. So clinical presentation might include headache, visual disturbances, confusion, abdominal pain, typically right upper quadrant, oliguria, peripheral edema, pulmonary edema, and so these patients are at great risk of seizure. So I'd want to get them the heck out of there and get midazolam ready to give in case they go into a seizure. So in terms of care, now I can get my slide to advance here. We're going to start an IV, SpO2, O2, all the usual stuff, and treat for seizure according to standard protocol. So eclampsia is defined as a seizure or coma in a preeclamptic patient, and likely due to hypertensive encephalopathy. Fortunately, it only occurs in about 0.2% of pregnancies, which is good news, but it is life-threatening. And intracranial pressure is the major cause of maternal death in eclampsia. Frightening, really, quite frightening. So in terms of management, as I said earlier, the usual stuff. O2, SpO2, IV access, prepare to deal with a seizure if you need to, and transport. Now we can get my slide to advance here, that'd be great. Okay. Gestational diabetes. So, let's see, this is just all stuff you already know. So consider hypoglycemia with any altered LOC in a pregnant patient. And we just treat them in the usual way with D50 glucagon if you can't get IV access. And neuromuscular disorders are quite a rare occurrence, but myasthenia gravis would be one concern, and that's an autoimmune disorder where the receptors for acetylcholine are destroyed. So these patients experience general weakness, abdominal muscle weakness, skeletal muscle weakness, chest wall weakness, those kinds of things, and can even lead to respiratory failure in patients who are in active labor. And it's a rare occurrence, so 1 out of every 20 to 40,000 pregnancies. And hopefully these patients are in hospital and are not calling 911. So anti-exacerbations, antepartum exacerbations are common, about 41%. And let's see, there we go, okay. So in terms of assessment, we want to look at the breathing carefully. Are they short of breath? Are they dyspneic? What's the respiratory and tidal volume like? What's their SpO2 like? They probably need supplemental O2. And these patients are not likely to have the strength to push to deliver. So even if you've got a mom who's crowning, now if the head is crowning to the point where the head is, you're pretty sure the head's coming out, then you may stay and deliver. But if the head is just appearing and then disappearing, I would probably transport. So SpO2, ECG, O2, PPV, PRN, left lateral position, IV TKO, and transport. It's not much more to do than that. I think we might, let's see, what time is it now? 9:46. I think we might stop here because technically we're only supposed to run until 9:50, and we'll talk about placenta previa and abruptio placenta the next time we meet next week. Do you guys have any questions up to this point? Just out of curiosity, pregnancy aside, have any of you had a patient with myasthenia gravis or Guillain-Barré?
Not a patient, but one of my cousins had it, and she didn't present with it though until after delivery.
Oh, really? Interesting.
So she didn't have the complications beforehand. It wasn't, and then the delivery happened, and then they ended up having to intubate her and put her into ICU for a few days.
Okay. Yeah, Guillain-Barré is an interesting neurological disease, Terry. It results essentially in slow paralysis of the muscles, not unlike ALS, except that so these patients remain fully conscious and slowly become paralyzed. It's usually, I think it's usually viral or maybe idiopathic, I'm not sure, but and they usually recover, unlike ALS. There's a really, really interesting book that I read many years ago. It was called Bed Number 10. It was written by a woman who had Guillain-Barré. She was in the intensive care unit on a ventilator, and the only way she could communicate was with her husband and with 2 or 3 nursing staff using her eyes, basically. And it was a very interesting book because she described, the horror of not being awake but not being able to move. And sometimes they would roll her into a certain position, and there'd be just a little crease in the sheet that would drive her insane for hours. And so she talked about it. It really gave me some. There were some really nice stories about some amazing, truly amazing nurses who really cared for her, and others who didn't seem to care at all. Who, one time there was a clamp that was attached to her, a metal clamp that was attached to her nasogastric tube, and she said she was rolled onto it and left on there on her side on this clamp for almost 30 minutes, and she said the pain was just unbearable. So it was a good story. It really gave you a sense of empathy for someone with that kind of a neurological disorder where they're kind of locked in. So yeah, it's interesting. But heaven forbid any of us should ever encounter a patient with either myasthenia gravis or Guillain-Barré who's pregnant. I wouldn't wish that scenario on anyone. I certainly wouldn't give a student ACP or PCP that kind of a scenario. That would be the scenario from hell. All right, so I think we'll call it a morning for this class, and we'll meet up again at 11 o'clock for the advanced professional practice class. All right, take care.